So my name is Simon Tavabie. I'm a palliative medicine doctor working in London in the UK. And like I say, I'm just very privileged to be invited to come and talk to you today about the Seeking Excellence in End-of-Life Care study that we completed and published earlier. Well, we completed it last year, but published it this year. So I thought as a starting point, it would be helpful to just give a bit of local context and a few key points to talk through. Sorry, my slides are not going forward. There we go. Going through for the UK. And so I suppose palliative medicine as a specialty has existed in some form for quite a long time, but more formalized in recent years. We go back and look at the hospice movement in the UK, which had its ties within religion, within sort of missionary work out of Catholic convents. And there were multiple hospices set up across the UK where really good holistic end-of-life care was being modelled. And eventually people started looking at where people were mostly dying, which was hospitals in the UK, and trying to take lessons from the hospice movement into the hospital. We knew that we as a specialty were never going to be able to see everyone who was dying, and so specialists such as John Ellishaw and his team out of Liverpool developed something called the Liverpool Care Pathway back in the late 80s and early 2000s. And that was a pathway that acted as an aide-memoire or a précis of some elements of holistic end-of-life care to try and remind our colleagues who are in the hospitals, those generalists or non-specialists in palliative care, of how they might be able to provide good quality end-of-life care to their patients. Unfortunately, there was some problems with the way it was implemented, and there was a controversy particularly around hydration and nutrition, and actually the Liverpool Care Pathway fell away within this controversy. And since then, we've not really had an agreed way that we support generalists in providing end-of-life care in hospitals in the UK. There have been reports such as More Care Less Pathway here, and the Leadership Alliance for the Dying Persons report, One Chance to Get It Right, which outlined some of the elements in terms of the priorities of the dying person. But unfortunately, that's not materialized into something a little bit sort of more solid that our colleagues can rely on when they're caring for dying people in hospital. Two more things just to note in context is that the way that we quality assure the end-of-life care of patients received in hospitals in the UK is something that we call NACIL. It's the National Audit of Care at the End of Life. And that's an NHS-wide incentive where hospitals can sign up to review the care of dying people in their hospitals once a year, as it stands. It's going to move to quarterly, but currently once a year. And they do so by case note review. So there'll be a set number. It's normally around 50 patients who've died, but they will review the case notes for evidence of good care. And they'll also conduct surveys of bereaved relatives and of staff to check their experiences of end-of-life care. And lastly, the Health and Care Act, which is an act of Parliament that came into law last year. And it may sound odd, but this was the first the first piece of legislature that ensured all citizens in the UK have the legal right to access palliative care. And that's specialist and generalist palliative care of good quality across settings and without any limitations on time, day of week, time of night, etc. So the reason that I think these bits of context are important is that we now have a legal right to be providing people with this care. We have a legal duty to be providing people with this care, and they have a duty to make sure that we're doing that. The way that we're currently evaluating end-of-life care is through retrospective review of case notes. And we're reviewing the case notes that are made by people who are not specialists in palliative care often. And as we found through the need for things like the care pathways that fell into disrepute earlier on in the context, actually the generalists do need a bit of help. They don't necessarily understand every aspect of holistic end-of-life care in the same way that a specialist might. And the reason that I've put Johari's window up is because actually when we're reviewing somebody else's notes, we're only going to be able to review whether or not the quality of care was good by their standards. And we're actually missing a huge part of the picture, which is their unknown unknowns. So there's a big gap in what we're doing in terms of our practice in the UK. So SEEcare, Seeking Excellence in End-of-Life Care, was our attempt to sort of try and look at a different angle on the problem of caring for dying people in hospitals. So the first pilot study was 4 trusts in the south of England, where we did multiple snapshot audits, where every single ward in the hospital was visited by a specialist in palliative care, and patients who were dying were reviewed against a set pro forma, and a significant unmet need was identified, and 56% of patients who were found needed intervention made by that specialist at that point in time. The Association of Palliative Medicine of Great Britain and Ireland found that shocking and interesting, and convened a working group of people with a variety of backgrounds, from medical, from nursing, from research, from data, from clinical governance, and from administrative sort of streamlining, to try and work out the best way that we could take this model and see how far it could go. We set some objectives, and I think the first objective was, well, we're used to case note reviews as a methodology. Will people accept this sort of prospective, proactive, going out to the wards and finding people and evaluating their care then and there? And we wanted to see whether or not that was acceptable to staff, particularly with workloads always being stretched, and whether it was acceptable to patients and their relatives. They didn't invite the palliative care team in, which is the normal model of referral that we have. Patients have to accept palliative care. And so actually being confronted by a palliative care specialist rather than asked whether or not they'd like to see one could have been an issue. We wanted to see the level of that unmet need that wasn't being picked up in other evaluations. And we wanted to see how much of that need translated in the need to make a change, because it's very possible that all of our patients will have needs every day, but actually some of them have a plan in place that doesn't need altering, and therefore they're receiving good care anyway. As a sort of sub-objective, because obviously we're still early stages at this point, we wanted to see whether or not there were any factors within patient or service design that influenced whether or not there would be higher or lower levels of need, or higher or lower level chances of the specialist needing to intervene. So as I'm sure you've seen from the study, we had registrations from sites. We gave them a 1-week window where they were to pick a day where they were going to visit every ward except for intensive care in the emergency department. And every adult patient who was dying that wasn't known to the team was reviewed against that standardized pro forma. In terms of the pickup, so we had 88 hospitals across the UK. So in all 4 nations, we had representation from hospital sites. On that one day, 284 patients were identified, which I suppose doesn't sound a lot, but for one day, it's reasonable that's a reasonable number. You can see from our demographic information here that the vast majority of our patients were over the age of 75. The vast majority of our patients were white or white other in their ethnicity coding. The vast majority were non-cancer patients, and a large majority of them were on medicine or frailty wards, which one might expect when you think about the kinds of wards where you'd expect people to be sort of okay at providing end-of-life care anyway. We asked, as I said, people to feed back their experiences of doing the work, and the proactive support and the outreach was warmly welcomed by wards. And actually, most teams felt that not only was it helpful in shaping future educational intervention and quality improvement work, but actually it helped build bonds by reaching out to people and asking, let me go and see that patient, rather than waiting for a referral. That built those bonds that have then allowed them to develop stronger working relationships. A majority of sites who gave the more in-depth qualitative feedback said that they wanted to include that within their annual audit schedule, so that they would continue to do some element of proactive outreach work and evaluation as a part of their normal audit and service evaluation. There were a few sites, I think it was 7 of the 35, that gave full qualitative feedback that questioned the methodology of identification, in that actually it seemed like quite a lot of work to walk around all of the wards in a big cancer centre to find maybe 1 or 2 patients. And so there probably is a way of streamlining it. But as some of the other sites said, the benefits of going to those wards and speaking to those clinicians actually may outweigh the steps that we count up in doing so.